have evolved over the last 1 decade. Now, before we discuss about the bronchoscopic interventions for COPD, various bronchoscopic interventions in COPD which have evolved over the last 1 decade. Now, before we discuss about the bronchoscopic interventions for COPD, we need to go a step backwards and we need to first discuss about lung volume reduction surgery. Okay, lung volume reduction surgery is something that was introduced for COPD emphysema in the early 90s, and the rationale for lung volume reduction surgery was that the removal or collapse of the damaged lobe of the lungs leading to improved aeration of the normal lung, and this was particularly used for patients having heterogeneous emphysema. That means if there was a heterogeneous upper lobe emphysema, that lobe was removed and that would improve the aeration in the normal lung. At the same time, the rationale is that decreasing the hyperinflation thus improves chest wall and diaphragm mechanics, improved elastic recoil and ventilation, and perfusion ratio to the normal alveoli. So this has been the rationale for lung volume reduction surgery, and we've seen with experience that several patients of lung volume reduction surgery have a significant improvement in their FEV1, their spirometry, and quality of life, 6-minute walk test distance. But not all patients have the benefit. Also, again we discuss about the rationale. If you look at this slide here, this is the dotted slide. The dotted lines show the size and shape when the lung is emphysematous, and the pink areas depict the worst area of emphysema. Now this depicts heterogeneous disease with the worst disease in the apices of the lobes. Now when we talk about lung volume reduction for emphysema, 1/3 of the lung is resected. The reduced thorax has improved mechanics. The reduced lung has better elastic recoils. However, air leaks can occur after inflation, stress on the staple line, and tissue torsion. So there are some patients who can end up with prolonged air leaks when LVRS is done. When we talk about surgical lung volume reduction, again this picture depicts actually what is happening to the lung. It's an hyperinflated lung. You're reducing the volume of the lung, and that translates into better respiratory mechanics, and it also diverts the air to the normal lung if you are doing this for a heterogeneous emphysema. But remember, this does not change the natural course of COPD or emphysema. And what we've seen with experience, and the literature also says the same thing, is the patients who have a benefit with lung volume reduction surgery, they have a benefit over a period of 3 to 6 months. It stabilizes for maybe plateaus for another 1 or 2 years, and then the decline begins. So, to summarize, lung volume reduction surgery improves shortness of breath, pulmonary function, exercise capacity, and the quality of life. And of course, there is a small subgroup of patients which have a survival benefit, and we'll discuss that. A very important trial, once this LVRS was introduced in the early 90s, a randomized controlled trial was called as the NET trial happened in the US. The paper was published in the New England Journal of Medicine 2003. It had more than 1,200 patients with severe emphysema who underwent pulmonary rehab and were randomized to lung volume reduction surgery or continued medical therapy. The NET trial identified a high-risk group, the patients who are at high risk from the procedure or the surgery, and that was a combination of FEV1 less than 20%, homogeneous emphysema, or a DLC of less than 20%. And this group of patients has an increased risk of death in the first 30 days after LVRS compared to the medical group, and therefore this becomes a contraindication for LVRS. The overall mortality was 0.11 death per person year in both the groups. There was an improvement in the exercise capacity at 24 months, 15% in the LVRS group and 3% in the medical group, and this was statistically significant. When you look at the subgroup analysis, this is a very important slide. In the subgroup analysis, the patients were divided into upper lobe emphysema and low exercise capacity on exercise testing, upper lobe emphysema and high exercise capacity, they had a good exercise capacity, non-upper lobe emphysema and high exercise capacity, and non-upper lobe emphysema and low exercise capacity. Only the group which had an upper lobe emphysema and low exercise capacity had a mortality benefit in the surgical group. However, if you had a non-upper lobe emphysema and you already had a high exercise capacity, the mortality was significantly higher in the surgical group. So the NET trial was really important to identify these subgroups and gave a lot of insight into patient selection and what the outcomes could be. However, lung volume reduction patients can have prolonged air leaks in up to 50% of patients. Air leaks require chest tubes and contribute to a cascade of adverse events. In-hospital mortality is up to 5%. 7% patients need to be reintubated, and this affects the length of the stay, the cost, the mortality, and the morbidity for the patients. Therefore, the idea came. This slide which I showed you earlier on, which has heterogeneous emphysema, could these be reduced without surgery and reduce the morbidity of surgery? The thinking also came from the ICU. In the ICU, often a bronchoscopist is called to do a therapeutic bronchoscopy. Somebody's got a mucus plug, maybe in the upper lobe, and that's caused a collapse, and that reduces the oxygenation of the patient. One goes inside, you do remove the mucus plug, and the ventilation improves. The idea was, could a plug be electively put into these areas and actually block the ventilation to those areas and reduce cause a collapse and reduce the volume of the surgery? And with that came the advent of valves. The idea of the valves would be implanted into the segmental bronchi. It would reduce ventilation to the selected portion of the lung to reduce lung volume and improve overall lung function. And that's when the era of bronchoscopic volume reduction began. The first prototypes which I used were in the year 2001, and it has really evolved well over the last 15 years. 2001 was when I was in Sydney. Now, how do you evaluate a patient for this? A CT scan is mandatory in evaluating a patient for volume reduction, to see for the presence of emphysema, to quantify destruction, to look at to characterize heterogeneous, whether it's a heterogeneous emphysema or whether it's a homogeneous emphysema, and to look for the integrity of the fissure for presence of collateral ventilation, and we'll discuss this more as we go down further. These parameters help in the selection of patient and the bronchoscopic lung volume reduction modality, along with the likelihood of benefit the intervention may provide. Now, we spoke about a CT scan. What is really required for patients when you're thinking about volume reduction is to have a volumetric scan. I mean, this is not the platform right now to discuss what a volumetric scan is, but the volumetric scan is a scan which will help us to quantify the amount of emphysema, whether it is homogeneous emphysema and whether it is heterogeneous emphysema. Now, collateral ventilation is something very important to understand. The earlier trials showed that in some of the patients, one could go and block the upper lobe completely, and there was still no benefit from collapse. The upper lobe was still ventilating, and patients were not getting benefit. The patients who were getting benefit were those who developed a collapse, and clearly that translated to volume reduction. How could it happen that their upper lobe, for example, one lobe is completely blocked and still there is no collapse? And that happens because of collateral ventilation. Interlobar and intralobar collateral ventilation is normal physiological phenomenon present since birth. The CT scan helps in the evaluation of the fissure integrity to assess collateral ventilation. A complete fissure is defined as more than 85% of the fissure present on HRCT in all the three axes, and less than 75% completeness of fissure indicates presence of collateral ventilation, and more than 90% rules out collateral ventilation. When collateral ventilation is in doubt, a fissure completeness is between 75 to 90%. There's a method called as an endobronchial method to check collateral ventilation can be used, and that is called as the Chartis system. The Chartis system comprises of a balloon catheter which can be passed through a flexible bronchoscope and is attached to the console at the other end. This slide shows the catheter in details, the balloon and the console. As the segment or lobe to be evaluated is occluded with the balloon, the rate of expiration is measured. If the rate of expiratory airflow remains constant, collateral ventilation is present. If the expiratory airflow gradually decreases, the collateral ventilation is absent. The difference between the fissure integrity and the Chartis system in assessing collateral ventilation is not as significant. However, in the era of personalized medicine, using both the modality yields higher accurate results compared to either alone. And this you will see gets more clear as we go ahead. Now, this is a video which actually demonstrates how the Chartis catheter is used. The catheter is passed into that particular segment, and once the catheter is gone into the particular desired segment, it is inflated. It is inflated in such a manner that the entire segment is blocked, and then okay, you see here the entire segment is blocked by the inflation of the balloon catheter, and then this is the Chartis console. Now, if you have a situation where, if you look at the first part of the image, the drop in the expiratory flow here, shows that there is no collateral ventilation present. And now, if you have inflated the balloon, and despite that, if you have the same expiratory flow maintained, as you see on the image on the right side, collateral ventilation is present. Now, if collateral ventilation is present, you know that only blocking the lobe is not going to be useful, and that will not help the patient in any way. The other workup required is a body plethysmography. You want to know what the residual volumes are, you want to know what the total lung capacity is, spirometry with diffusion capacity, echocardiography, you need to look for pulmonary hypertension, and of course VQ scans are carried out by some centers, some in Europe, particularly Switzerland, where their role in to look for, and identify areas which should be targeted based on the perfusion. So you would really want to divert the air to an area which is not only ventilated but also has perfusion present. What are the indications for bronchoscopy volume reduction? Very similar. They are extrapolated from the lung volume reduction surgery indications. The age is 40 to 75, FeV1 20 to 45%. Hyperinflation has to be present. Diffusion capacity more than 20%. PO2 more than 45%, 45 millimeter of mercury, and a CO2 less than 50 millimeters of mercury. 6-minute walk test distance should be more than 150 meters. Patient should be not smoking for the last 6 months, should have not had a recent exacerbation, and should have dyspnea despite optimal medical therapy and pulmonary rehabilitation. Contraindications are presence of giant bullae, alpha-1 antitrypsin, previous thoracotomy, current smoking in the previous 6 months, a significant amount of bronchiectasis, pulmonary hypertension on echocardiography, active infections, unstable cardiac conditions, pleural or interstitial changes on HRCT chest, and any coagulation abnormalities. Now, as I said, the idea came that valves would be put in, or plugs should be put in. There are two types of valves which have evolved over the last 1.5 decade. Both can be placed with a flexible bronchoscopy to completely occlude the the desired segment. One-way valves allow air and secretions to drain from the distal segment, but do not allow air to enter the target lobe during inspiration, and that's the whole idea of actually collapsing the distal lobe, at the same time allow secretions to drain so that there is no post-obstructive accumulation of secretions. They are held in place by coated self-expandable nitinol retainers, and the indications of use of valves are heterogeneous emphysema with absent collateral ventilation. So if you've got heterogeneous emphysema, say again, for example, in the upper lobe, collateral ventilation is not present, then the chances that the valves would work and lead to a benefit to the patient is higher. These are the two valves. One is the intrabronchial valve and the other one is the endobronchial valve. Now, as we go into the more details, the endobronchial valve has actually evolved was one of the first valves to be introduced. It has evolved over the last 15 to 17 years. They are available in two sizes, for the lobar bronchi and for the segmental bronchi, and a clinical significant improvement in symptoms and quality of life were achieved in patients where atelectasis of the target lobe was achieved. We've discussed that if you have no collateral ventilation, you've blocked the lobe, the chances of getting atelectasis is higher, and that would translate to a benefit to the patient. Completeness of fissure more than 90% on CT scan is mandatory before considering placement of valves. However, a study has reported insignificant improvement in patients having a complete fissure but the presence of collateral ventilation with Charter system. So it's really very interesting that even if you've got a complete fissure, it might be worthwhile to check for collateral ventilation with the Charter system and also prove that yes, there is no collateral ventilation, and that would increase the chance of success and would help you to select the patients more correctly. Endobronchial valves, this is a schema video which shows it's a minimally invasive, it reduces lung volume, it modifies airflow in the lung, and as you see here, it can be placed with a flexible bronchoscope, and this is the catheter delivery system. You will see here that there's a duckbill valve here, and what happens in this is that in expiration the valve opens and allows the distal air to be expired, but it closes during inspiration, thereby preventing the inspiratory air going into the distal segment. And as you see here in the schema, you can have multiple valves placed in the multiple segments, and that's how you would target the entire lobe. Now this is a video of again how the endobronchial valve device delivery system works. As I said, this is done under a flexible bronchoscopy and sedation. As you see here that the two markers here are they tell you about the sizing and the adequacy of the size of the valve, and you see here that the valve is deployed. As the segment where the valve is deployed, also the segment at number 11 at 11 o'clock also shows a second valve in place. So this is how a endobronchial valve is deployed, and you see here in this picture here the video has stopped at a position where the duckbill valve is open. That means it has been captured in expiration. It allows air to come out during expiration. The IMPACT study, however, reports meaningful benefit of endobronchial placement in homogeneous emphysema also, but without collateral ventilation. That means you might have homogeneous emphysema. The question is, should we use these in homogeneous emphysema? And there are some studies which have shown that in homogeneous emphysema, if that lobe does not have collateral ventilation, that might actually help the patient to a certain extent. So this is the intrabronchial valve. It's an umbrella shaped valve. It's available in 4 sizes. The intrabronchial valve is anchored to the endobronchial valve with the help of a hook like projections and depends more on the bronchial wall. This is a schema video of how the intrabronchial valve or the spiration valve is placed. Is done using flexible bronchoscopy. A preloaded delivery catheter is passed through the working channel of the bronchoscope here, and then you go into the desired segment. Once the catheter reaches the desired segment, the valve is deployed, and it blocks the air going into the distal segment. It allows the drainage of mucus from the sides. So now this is the video which shows that valves placed, 3 valves placed into the particular segment, and this video shows that the valves placed in all the segmental bronchi of the target lobe. This video shows that if the valves have to be removed, they can be removed very easily using the biopsy forceps, again under local anesthesia and sedation. The tip of the umbrella can be just captured with the forceps and can be pulled back. So these valves can be very easily removed. The complications include exacerbation of COPD, pneumothorax, hemoptysis, valve migration. Pneumothorax is the most common complication and occurs around 4 days after placement. Patient should be observed 3 to 4 days after the procedure. And a study reported that the incidence of pneumothorax was associated with the achievement of a target volume reduction. And we know from experience and from the literature that actually if the collapse is quite significant, a pneumothorax might occur. And these are the patients who are actually likely to get a better symptomatic benefit than those patients who do not get a pneumothorax. The other technique, which is called as the lung volume reduction coil, can be also deployed for volume reduction. The principle or the rationale is to restore the elastic recoil. It improves lung compliance and shift preferential filling from disease to the healthy lung, to reduce air trapping and hyperinflation, and to maintain airway patency. Lung volume reduction coils are preformed nitinol devices, as you see in the picture, that can be placed via flexible bronchoscope into the target lobes. The coils are placed under general anesthesia or conscious sedation with the help of fluoroscopy. A thin guide wire is initially inserted to the target lobe under fluoroscopic guidance. A catheter with the coil is then passed over the guide wire and deployed under fluoroscopic guidance. The coils regain their shape after deployment, thus causing a collapse of the target lobe and reduces the lung volume. It actually shrinks the target segment. This is now, if you look at this slide, the pre-treatment schema shows that there is a loss of elastic recoil, which leads to an early collapse of small airways. There is a difficulty in exhalation due to decreased elastic recoil of alveolus, narrowed bronchial and air trapping, and post-treatment with the lung volume reduction coil. There is a restoration of exhalation. There is a restored elastic recoil due to the lung volume reduction coil, which holds the airway open, and there is an improved exhalation due to increased elastic tension and reduced air trapping. So this is the rationale of how the lung volume reduction coil would help the patients. What are the advantages of using the coils over the valves? They can be placed in both heterogeneous and homogeneous emphysema. The presence of collateral ventilation does not affect the outcome, because actually the coil goes and actually pulls back, pulls down or collapses the distal segment. They can be used for bilateral emphysema. However, the second lung is to be treated with coils 1 to 4 months after the first procedure. The removal of coils after deployment is, however, difficult and may not be feasible in most cases, and for practical purposes it cannot be done. The effect and the efficacy of coils in improving the lung function and quality of life is reported in randomized trials. The complications include exacerbation of COPD, transient chest pain, pneumothorax, pneumonia, hemoptysis, and majority of the complications occur in the initial few weeks after placement. However, minimal hemoptysis in certain patients can last for a few months. Another technique is the bronchial thermal vapor ablation. It consists of delivering heated water vapor through endobronchial catheter to the target lobe, and the rationale is that with that inflammatory response it leads to scarring, and healing with fibrosis causes reduction in the lung volume. The catheter is a single-use catheter with the balloon. I'll show you in the schema how it works. The heated vapor at 75 degrees is delivered within 3 to 10 seconds based on the dose. The inflammatory response, comprising of fever, cough and excessive sputum, develops after bronchial thermal vapor ablation, and that may prolong hospital stay. Now, if you look at the schema here, the flexible bronchoscope is advanced to the desired segment. The catheter is advanced into the segmental bronchus. The balloon is inflated, and once the balloon is inflated, the steam is given to the segmental bronchus. The balloon has to be inflated quite well so that the steam does not come at the back. A pilot study has evaluated its safety in a small number of patients. There's another study of 44 patients evaluating its benefit in FEV1 and 6-minute walk test distance at 6 months. However, this study had a high rate of complications. They used a high dose of heat energy, 10 cals per gram, and reported 29 serious complications, including exacerbation, pneumonia, and death. And therefore, in the step-up study, the subsequent study, the dose was reduced to 8.5 cal per gram, delivered over 2 steps to reduce complications. And these patients reported a significant improvement in lung function and quality of life at 6 months. The most damaged segments was treated first, and the subsequent segments were treated after 3 to 4 months following the first bronchial thermal vapor ablation. The advantage of bronchial thermal vapor ablation is that the outcomes are better despite the presence of collateral ventilation, because in rationality actually there's inflammation and scarring, and that actually collapses and causes atelectasis of the distal lobe. This is an air seal system which is also available, and basically what this system utilizes is a polymeric substance and a cross linker that must be mixed before installation in different syringes. The foam sealant is delivered in the subsegmental bronchus through a catheter with its tip position 2 centimeters beyond the bronchoscope. The foam sealant will flood the submental bronchus after delivering and thereby cause a collapse. To summarize, bronchoscopic lung volume reduction has emerged to be an important technique in the management of patients with emphysema. The body of evidence for bronchoscopic volume reduction has expanded over the last decade. Patient needs to be worked up thoroughly by specialized center for optimal patient selection, and it's really very important to understand that the technique needs to be personalized to every patient. Collateral ventilation is an important determinant for the type of technique to be utilized for bronchoscopic lung volume reduction and eventually the success of bronchoscopic lung volume reduction. Also, the type of bronchoscopic lung volume reduction technique needs to be chosen for a selected patient using multiple clinical and investigative parameters. You cannot only depend on the Fisher integrity, for example. You might need to combine that with the Charter system so that the treatment option can be personalized. In well-selected patients, bronchoscopic lung volume reduction can lead to a improvement in lung function and quality of life. Thank you very much.